Okay, so because varicose vein ablation is, we have a lot of experience in China. A lot of doctors are using it, and they have quite good feedback. But in international market, we don't have many doctors who are using it in their practice, and I think we still need to do a lot of collect a lot of data, and that is what we are doing at the moment, trying to work with more experts to have more data, have more evidence in the microwave ablation and the venous treatment. So at present, we don't have much questions, but if you would like to share your questions, we can go ahead with it now. Professor Tang, do you have any questions for Dr. Rossos or Professor Yang?
I do, actually. Let me ask you, let's start off. I mean, you guys have got the most experience using microwave. Probably my experience in Singapore is primordial compared to you guys. I look at your skin burns rate between 5 to 10%. That seems to me a bit high. How is that your early experience? And is there ways that you would advise the people watching how to minimize that risk? Because really, skin burns shouldn't really happen in any kind of thermoablation technique if you're experienced enough. And with the probe only at 85 degrees, and there's a 3 centimeter warning sign before that end of that probe, should we really be getting those, to be honest with you? Yes, I know the vein can be very close to the skin surface, but you use the tumescence skillfully to push that vein off the skin surface so that you can safely ablate the vein. So I ask you, I mean, should we really be getting any skin burns really in a person who is quite skilled in actually doing quite a lot of thermal ablation?
It's a difficult problem because earlier when we tried to use the first generation generator and the first generation probe, the flexible antennas, the generator was without the timer. We feel and we wait in the 1, 2, 3, 4, 5, 6 second and the next step. And the operating stress was it's very higher because we couldn't. Where is the probe in the subcutaneous or the great saphenous? And then a lot of times in early, it's earlier, we couldn't find, it's at the end, it's the very end of the operation, and the high temperature is caused the local ring style skin burst. We think it's necessary to know everybody who try it, if it the really dangerous. If we use the tumescence, it's the different, because the tumescence is different the thermal problems. The first operating, we couldn't use every time the tumescence because the general anesthesia, it's without the pain, and we use the tumescence fluid only. The patients haven't got it's a minimum 1 centimeter subcutaneous fat. And this produced the early times the skin burst. Today's is we know this problem, and the last 20 or last 40 legs we operated without the skin damage.
What about Dr. Yang? What is his thoughts about it? Because he's reported like what was it, 1 to 10% risk of skin burns in his series. Would appreciate how he's dealt with that and share his experience of how to minimize that risk with this device.
I couldn't see the young colleagues.
杨主任，您在线吗？
Okay, well, we can go on with another question then. Let me ask you, therefore, with your wealth of experience, for the small saphenous vein, would you change the protocol that you have? I noticed your protocol is very different from the Whiteley protocol, whereby you use 50 watts. Now, 50 watts is obviously higher than the 40 that I use. And the data from the Thai data suggested that anything above 50 and above, there's risk of not much efficacy benefit, but higher risk of thermal damage to the surrounding tissue. Do you do a different protocol for your small saphenous vein ablations?
Yes, yes. Below the knee is it's a different protocol because the 50 watts and the 5 minutes we use only the femoral region. The femoral region used it if we operating with the general anesthesia. If I use the tumescence fluid, the longer termination and if we use the local anesthesia with tumescence, we use the Whitley 47 second. In the upper knee and the short saphenous vein, we use the 30 or 40, 3 or 5 second.
Do you get similar efficacy rates with that in terms of ablation and no recurrences with that shorter burst, as well as a lesser lesser wattage as well?
I choose the 40 or 30 and 3 or 5 secondum, the short saphenous vein diameter. If it over the 8 millimeter, I use the 40 and 5. If it under the 8 millimeter, I use the 30 and 3 or 5. It's different because the patient's condition and the saphenous vein condition is a lot of different. I think is necessary the smart logistic that we use
Sure.
typical.
So with the lower wattage, the 30 to 40 watts with the 3 to 5 second less number of seconds used, is your efficacy rate the same in terms of occlusion? Are there any recurrences with that lower regime compared to the 40 watts and 7 seconds that we use for the greater saphenous vein?
Yes, but the great saphenous vein, if we
My question is the efficacy the same using that for the smaller saphenous vein? I'm sure that's what the audience want to hear, is to see whether that's any benefit compared to going straight to the 40 watts and 7 seconds regime.
In the first year, I used only the 15 and 5 second, and after 1 year, my practice little bit changed, and I controlled now the patients, and today I don't know big difference is the two thermal techniques. That's the same, the occlusion rate. And when I use the great saphenous ablation with the flexible antenna in the crural region, a lot of situation I changed the what's for 40 and the 6 or 7 the not find different occlusion results.
So no difference between the two regimes that you're talking about.
Yes,
so just to let me ask you, where would you put the tip of the probe in your small saphenous vein ablation? Because you don't really know where the saphenopopliteal junction is. And that's always the worry, especially with sinoacrylate glue ablation. No one really knows where you put it. Normally you put it 5 centimeters from the saphenofemoral junction. But in the saphenopopliteal junction, you've got a bit of a dive of the small saphenous vein going into the popliteal.
Yes.
So where would you put your catheter in that respect for microwave? And is there any tips that you would give the audience regarding tumescence around that area to minimize the risk of E-hits?
The popliteal region and the connection, the short saphenous vein and the deep vein is a very different anatomy. In my practice, they use the technique when the corner to the deep vein, and I start this point the coagulation. If not the direct connection to deep vein, the popliteal vein go up and, for example, to the upper femoral sides, I use these probes at upper and the coagulation upper it, because my opinion, the reflux this way and the reflux is this way, it's possibility, it's necessary to occlusion the upper veins too.
So what you're saying is that we don't need to go past the fascial curve and dive into the muscle area, because the risk of DVT, I suspect, is going to be higher, and the risk of E-hits will be higher by doing that. Is that correct?
Yes, the duplex ultrasound examination in my practice is a minimum 30 minutes, and I try to every segment diagnosis, and I plan the operating techniques in the different anatomy, and if I see so it's a difficult problem. I consulting the friends and radiology colleagues.
Let me ask you, therefore, with varices, and I think Dr. Yang put on it, why don't you just avulse the varices rather than ablate them? I mean, you put the thermal ablation inside the varices. Why don't you just avulse them? Because what you're doing is, by coagulating the blood within the varices, you're going to cause a hematoma there, and the risk of that hematoma is quite painful. Why don't you just avulse them? You're already under general anesthetic. Why don't you just avulse them? Do you get a good cosmetic result with just the ablation of those varices? Or do you actually, the varicosities, the truncal branches? Wouldn't you just get the same effect by just avulsing them?
Sorry.
So my question is, I think Dr. Yang would be more appropriate to answer this question, is that you've been ablating the truncal varicosities, the side branches, with the device as well. I don't do that. I avulse them if there's truncal varicosities. I don't believe in them. If you ablate them, you're going to cause a hematoma and a blood clot under that skin, and that's quite painful, and it can get infected. My asking is, you do this procedure under general anesthetic anyway. Should you do the phlebectomies, the avulsions, rather than using the device to ablate the varices?
Yes, in my practice, I don't remember the painful hematoma when we try to close the branch varicosity. I use the rigid antenna, the branch varicosity, and if I use the laser fibers, we use the branch varicosity, and we use a lot of times the foam sclerotherapy in operating step, or the controlling steps. The patients who treated only the thermal coagulation, and I compared treated the thermal and the foam and other endovenous technique. Everybody is satisfaction. Earlier we used the other techniques, the stripping technique, the side varicosity, the Varadi or the Smetana equipment. The patient was the problem only this region, not the thermal and the endovenous techniques. And today we use only endovenous techniques, the thermal and non-thermal techniques combination if it's necessary. And we never seen the big hematoma, and the painful hematoma is never seen in my practice.
Fair enough. Fair enough. So, I mean, I think with this workshop, I think what the 3 talks have really suggested, and I'd say that to the audience here, is that I think what we can conclude from the 3 talks is that microwave ablation compared to either laser or RFA is actually an equivalent, if not superior, in my opinion, technique. I think in terms of pain, there's much less. In my hands in Singapore, and I think with my colleague in Singapore, we haven't got any numbness despite taking the device below the knee for dealing with C6 disease. I think in terms of bruising, I think the bruising scores are much improved than laser and RFA. And I believe as well that the pain scores within the first 2 weeks after the ablation is actually comparable to a non-thermal, non-tumescent technique. Have with microwave, and I think especially in Asian patients, the pain threshold is much less. So I think you probably have to do this under some sort of either sedation and local anesthetic. And I don't think you can do this purely under local anesthetic. And I think for the bigger veins where you don't want to leave a foreign body like glue, I think it's ideal. And for those which are the veins just below the surface, the N13 vein, people are told not to use a foreign body in those kind of situations. You actually can push the vein very carefully using tumescence off the skin surface. So you don't need to actually burn the skin. And I think that's a very important technique. And I think you can reduce, and this is much better than RFA in its respect, that you can reduce the temperature. Now I go with a lower wattage than most people. And I use the Mark Whiteley's protocol. Actually, I reduce it even like to 35 or 30 and increase the number of seconds. And I can keep moving the catheter. But so actually, it's actually a very versatile catheter in that respect. And that's what I found from my experience using it in Singapore. I prefer using it than leaving a lot of glue in very big veins, because I think that's a very dangerous thing, because you don't kill the cells, you don't kill the adventitial side. By not killing the adventitial cells, there's always a risk of a hypersensitivity reaction. And then you see that typically can happen 6 to 12 months after the procedure. Whereas with a killing process such as a thermal technique, and with this way you get transmural death, the recurrences should be even lower than you get with RFA. And if you look at the current RFA probes, specifically the one, it's just a heating probe. It is not a proper RFA catheter as they sell it to you. Would you agree with that?
Okay, not different, but I prefer the laser and the microwave combination, because I learned earlier the laser techniques, and I haven't got lot of good results with the RFR, and I chose the laser and the microwave and use the foam and the glue. In this combination, it's enough every patient's problem solution.
I must admit, I've got a few more minutes to speak. You want me to speak a few more, or do you want to cut it short?
We have a couple of questions in the audience.
Very good. So. Let's answer those questions. So I'll give you time to get those questions out.
Yeah, thank you. The one question is, is there a risk of pulmonary thrombosis during or after microwave treatment?
Dr. Roosevelt, would you like to go first, or would you like me to speak about that first?
Yeah,
You have more experience.
we use the short time low molecular weight heparin prophylaxis, anticoagulation prophylaxis every patient. If the patient is a high risk, with a high risk is a obesity and diabetes and hypertension and other, we use the low molecular weight heparin treating 2 or 3 weeks minimum. I'm very happy because we couldn't see the deep vein thrombosis after the operating my patients.
Yes, likewise. In Singapore, our experience both here at SGH and at National University Hospital with my colleague, we've had no pulmonary embolism and no DVTs. And I actually put the catheter closer to the saphenofemoral junction than I would with an RFA, because you don't need to put the head down. And I think the spill also with the risk of with E-hits, I think is less. In terms of anticoagulation, if I'm doing just a EMA plus or minus avulsions, I will give them one-off dose of Clexane or subcutaneous heparin. I don't really favor the use of, and some of my colleagues actually don't give any heparin perioperatively. They think the DVT rate is actually less in Asians than they are in Caucasians. But saying that, I mean, there's some we use a Caprini score, and if there's a higher risk, then obviously you should be giving them a longer period of time. But I don't think we do really practice that in Singapore.
Okay, thank you. We talked about the pain score of microwave ablation, but there is a question asking how painful is microwave ablation compared to laser ablation, and regarding recovery time, is there a significant difference between the two approaches?
First, me.
Oldest first, and person who's used the most laser. I've stopped my laser practice since I've been in Singapore, so I don't actually use it anymore. And I actually think it causes a lot more pain than RFA, let alone microwave.
Yes.
Go ahead.
When I start to use the laser ablation, and I get every patient the painkiller drugs, and they are not used it, and so they not need the drugs after the operation, because not pain, not cause the continuously pain. And the patient early mobilization is very good, the early go back to work is a very good technique. The pain problems, and when we use the microwave, we compared the laser after the laser operation, what a different in the pain, and the no different the pain. We think, in my opinion, not need the continuously the painkiller after this thermal operation, because not caused the big tissue problems, and the early mobilization, the better thrombosis prophylaxis, and better the life without pain.
I mean, I'll be honest with you. I think laser causes a lot more pain, and theoretically it should. With a higher temperature probe, it can cause much more destruction. You also have the disadvantages that you need to do this in a laser-approved lab as well. And I've stopped my laser practice because, oh yes, it gives you a bit more definition. It gives you more flexibility in what you want to do. Actually, the fiber goes round curves a lot better than our catheters are currently, but I think with microwave, I think you get a lot more less pain, and I noticed you get a lot more bruising as well, and a lot more bruising than RFA, which obviously has less effect than laser in itself. So yes, I think to answer that question, and you look at the pain scores that we got from the Maestro study, they're actually comparable to what you're getting with non-thermal tumescent data as well, from both from the US registries, as well as from our own ASVS registry from Singapore. So yes, I think it does give you much less pain and much bruising.
Thank you, Dr. Tang. And we have one last question saying, if the patient takes hypoglycemic drugs before surgery, can microwave ablation be performed?
So the question is the use of hypoglycemic drugs, is that right?
Yes.
I don't see that being a problem. It depends on how you're dealing with the patient in terms of your perioperative workup, whether you're going to have a general anesthetic and your protocols for diabetic patients. But I don't see that being a problem at all. No, that's not one of my considerations. No. If you do it on the local, I'm sure that you don't even need to starve them. So, I don't think that's an issue.
Yes, the question is the high risk patients operating is, I think, is not problem because we use the local anesthesia. The diabetic patients use the drugs and normally use the insulin isn't normally because not the difference the life only 1 hour in the operating room and they are go back your life. It's not the difference. I think the anticoagulant patients the same. It's not the stop the anticoagulant drugs because after operations go back the normal life. I think it's the thermal operation with the local anesthesia or the short laryngeal general anesthesia is not stopped the life. It's a very small period and go back your normal life and normal work.
Okay.
Yes. Okay.
Thank you. Yeah. Thank you. Well, actually. Okay, so Dr. Tang, Professor Tang mentioned about the compression bandage like after 24 hours after the operation. So not long ago, in response to the needs of some of our end users, we started to offering the elastic stockings with the function of compressing blood vessels and hemostasis. So it is CE approved and can be used before or after microwave ablation. It looks like this. I don't know if you use it in your practice.
Yes. Yes, the first day we used the bandage in operating room. We used the after 1 day. The patient changed the bandage, did the compression stocking, and that's the same compression stocking, and they are used it as a 2 or 4 weeks, depend the earlier varicose status.
Okay, okay. I mean, normally, how long would you recommend the patient to wear it?
The patients who suffered the CEP 3 or 4 without the ulcer, is 2 weeks. It's enough. After 2 weeks, when we make the control examination, and this time is the patient of the compression stocking and not back, who suffered the pre-ulcers. It's a very big induration and very big colorization and other pre-ulcer or ulcer. The necessary to use minimum 4 weeks or the ulcer healing date.
Okay, okay. Thank you very much, Dr. Rossos. So yeah, I mean, if you need it, you can just contact our local representatives, because right now it's available along with the catheters, the probes. So if you need it, you can contact us. Thank you. Okay, so the discussion was very fruitful and very informative, and I think that is pretty much everything that we can cover for today's webinar. And thank you very much for the excellent lectures and for the discussions as well. We appreciate your effort for the webinar. Thank you very much, Professor Tang, Professor Rossos. Thank you. Dr. Yang, I think he's in the operation.
Yes,
Thank you very much for having us.
much.
Have a nice evening.
I believe you are satisfied and everybody is happy.
Yeah, it's very informative, and I believe the audience benefited from it. And if we have more questions from the end users regarding how to operate the microwave ablation on varicose veins, we will come back to you if that's okay.
Absolutely.
Yes, I would like if you organize the results data is collected and the organize the roundtable the possibility to collect the results analysis.
So, Mr. Van, can I ask you quickly before we go, is your paper that's coming out in Acta Phlebologia, is it actually in English or is it in Hungarian?
No, it's in English. This is the Acta Phlebologia is the Italian editors, and the English you find in the internet.
Oh, would you mind sending me a copy of the English publication?
Yes,
I'll be very happy to read it. There's not that many publications on microwave in the press.
If I get your email address from Dana, I will send you the English paper. Okay.
Thank you very much. Appreciate it.
We will share the contact, the email address of Dr. Tom. Okay.
Thank you.
Thank you very much. Bye bye.
Have a good evening, guys. Nice to see you guys. And thank you very much for the invite. Take care. Bye bye.